Greetings. I hope you are enjoying the 2021 Annual Clinical Assembly so far. My name is Nathan Vangelovich. I'm a pediatric otolaryngologist at the University of Rochester Medical Center in Rochester, New York. It is my pleasure to discuss pain management after tonsillectomy with you today. I have no disclosures. We will start by discussing tonsillectomy and the pain which is associated with this procedure. We will then move on to perioperative considerations, covering preoperative, intraoperative, and post-operative strategies for pain management. Let's dive right in. Tonsillectomy is one of the most common procedures performed in the United States per year, with a few 100,000 performed annually. Although performing a concomitant adenoidectomy adds to total operative time, performing a tonsillectomy with adenoidectomy does not confer greater postoperative pain compared to tonsillectomy alone. Therefore, for the remainder of this lecture, I will refer to the procedure as tonsillectomy, with the knowledge that adenoidectomy may also be completed. Gerber-Shagan and colleagues compared 179 different surgical procedures across various surgical specialties and found that tonsillectomy ranks in the top 25 most painful procedures. Specifically, tonsillectomy was number 24, despite being considered a minor procedure. It was the most painful of all otolaryngology procedures that they included in this study. When postoperative pain and opioid consumption were reviewed, specifically compared to other otolaryngology procedures, tonsillectomy had significantly higher pain scores and opioid consumption. With respect to all procedures, there was no effect of sex, marital status, or education level on postoperative pain or opioid use. Postoperative tonsillectomy patients used pain medication longer when compared to other otolaryngology procedures. Guntinus Licius et al. Performed a prospective study of about 2,500 patients in an attempt to identify risk factors specifically for higher post-tonsillectomy pain. They found age less than 20 years, female gender, no preoperative pain counseling, and a history of chronic pain were all independent risk factors for higher post-tonsillectomy pain. Because tonsillectomy is a very common procedure and the postoperative pain is significant, especially when compared to other otolaryngology procedures, managing this pain without increasing the probability of postoperative bleeding is an important topic. Sarni et al.'s prospective study of 232 adults identified 5 different pain profiles over time. More than half of the patients followed the type 2 curve, which is highlighted in red, where pain intensity slowly improves with time. Types 1, 3, and 5 were found in about 15% of patients, and type 4 was extremely rare. Let's start from the beginning. The patient has elected tonsillectomy and they are in your clinic. The preoperative conversation has been found to be extraordinarily important. It can be broken down into education, which includes expectations, and establishing a clear plan for postoperative pain management. Crandall and colleagues investigated whether providing an educational booklet and teaching through this booklet in clinic was helpful. They found that 96% of patients in the intervention group reported that the booklet, as well as the additional teaching, helped with postoperative pain. These patients specifically mentioned that learning the 0 to 10 numeric pain intensity scale helped manage postoperative pain by guiding medication timing based on actual severity. It also allowed the caregiver to understand the patient's level of pain. Lee et al. Found a wide range of parental perception of pain and their ability to assess pain. Pain severity fluctuates throughout the day, and proper medication counseling specifically related to opioid administration, was reported to be very helpful. To summarize, preoperative education should include expectations, including the role of the caregiver. This education should discuss misconceptions, teach the patient and caregiver how to assess and describe pain, and include a clear plan for pain management. Now we move on to intraoperative considerations. What can we do in the operating room to reduce postoperative pain? Let's start with intraoperative steroids. Many sources, including the clinical practice guidelines, meta-analyses, and randomized control trials, recommend the administration of a single intraoperative dose of dexamethasone. In addition to postoperative pain, this single dose of IV steroid is also effective for postoperative nausea and vomiting and can minimize inflammation around the tonsillar fossas. The remaining medication we will discuss seem to have variable efficacy, depending on the study. Many are administered by the anesthesia team according to their protocols. Intravenous acetaminophen has become fairly common for intraoperative use. It is particularly helpful when attempting to reduce perioperative opioid administration in patients with obstructive sleep apnea. Overall, IV acetaminophen decreases postoperative opioid use. When compared to an intraoperative dose of an IV opioid, there does not seem to be a significant difference, meaning IV acetaminophen can be administered instead of a narcotic and postoperative pain control is about the same. Except in very specific circumstances, intraoperative antibiotics and postoperative antibiotics for that matter should not be administered. They have not been found to assist with postoperative pain and do not reduce the risk of secondary post-tonsillectomy hemorrhage. Ketorolac is an Nsaid which has been studied in the adult and pediatric populations, mainly for intraoperative and immediate postoperative administration, meaning in the PACU. Past advice, including the 2011 Clinical Practice Guidelines, recommended against the use of ketorolac, citing postoperative hemorrhage rates from 4 to 18%. Since that time, additional research has been completed. Chan and Parikh performed a systematic review and meta-analysis and concluded that ketorolac is safe for children, but inferred a 5-time increased postoperative bleeding risk in adults. McNoll, Rowe, and Cooper reported similar postoperative pain scores when opioids were compared to ketorolac. There was insufficient data to comment on post-tonsillectomy bleed rates in their study. The retrospective case series of 1,300 patients by Rabbani and colleagues concluded ketorolac decreased narcotic use and did not increase the rate of post-tonsillectomy hemorrhage. Injection of a local anesthetic is common in some otolaryngologist practices, despite previous clinical practice guidelines recommending against their use, citing a 1999 Cochrane review, which included randomized controlled trials of adults and children that found no evidence that the use of local anesthetics improved postoperative pain control. Recent literature, although often underpowered, has shown some benefit in postoperative pain, swallowing, pain with speaking, and the ability to get rest. The impact on post-operative pain tended to be greatest in the first 24 hours after surgery. There are a few other intravenous medications administered by the anesthesia team to be aware of. Ketamine, only for use in children, dexmedetomidine with the brand name of Precedex, and gabapentinoids. These medications are typically considered when first-line analgesics are contraindicated or for patients with other specific concerns. A meta-analysis completed by Cho and colleagues found that ketamine reduced postoperative pain severity when compared to controls and had similar pain outcomes when compared to opioids. There was no difference in adverse outcomes, including increased sedation, nausea, vomiting, bad dreams, worsened sleep pattern, and hallucinations. Dexmedetomidine is often added if there is a concern for emergence agitation. There are various sprays, gels, and patches which can be applied to the surgical site after the tonsils are removed. Most of us are likely familiar with these in the context of controlling intraoperative or postoperative bleeding. However, their use has been proposed to reduce postoperative tonsil pain. In theory, these agents protect the tonsillar fossa and promote healing and mucosalization. Although they may help with controlling intraoperative bleeding, the data regarding pain and speedier mucosalization is inconclusive. Now on to a very controversial topic. We all have our preferred technique. We probably have all found evidence, either in literature or anecdotally, to support our choice of instrument. After digging, I decided against discussing technique in detail because we could probably debate this all day. So I decided to stick with highlights and recent evidence from large powered articles. We can open technique for discussion during the form time if needed. One technique that has stood the test of time is cold tonsillectomy. Cold tonsillectomy has been found to reduce post-tonsillectomy pain. However, it has been associated with increased intraoperative and postoperative bleeding and a longer operative time. Intracapsular tonsillectomy, also known as tonsillotomy and partial tonsillectomy, have been shown to reduce postoperative pain, analgesia requirements, secondary post-tonsillectomy hemorrhage, and readmissions. It is associated with higher postoperative satisfaction, both in pediatric and adult patients. To summarize, one intraoperative dose of steroid is strongly recommended. This helps with postoperative pain, nausea, vomiting, and inflammation. Consider the use of intravenous acetaminophen and think about what technique you want to use and why. Injection of a local anesthetic may be helpful in the first 24 hours, but there are some risks associated. The use of antibiotics and topical materials, specifically for postoperative pain, is not recommended as the data does not support their use. Postoperative considerations. Before discussing things that work, we need to highlight two medications that should not be used post-tonsillectomy for patients less than 18 years old. Although this is probably old news, an alarming percentage of otolaryngologists are still prescribing codeine to children. The FDA issued a black box warning August 2012, contraindicating codeine prescription after tonsillectomy for patients less than 18 years old, after a number of deaths were attributed to the use of this medication. Most of these deaths were in patients with an underlying pulmonary comorbidity, such as obstructive sleep apnea. Some patients are rapid metabolizers. When codeine is rapidly converted to morphine, respiratory depression can ensue. Similarly, there is a black box warning for tramadol, contraindicating its use in post-tonsillectomy patients less than 18 years old for similar reasons. This chart is for your reference and contains a list of medications which contains codeine or tramadol. The strongest recommendation for post-tonsillectomy pain control is alternating between acetaminophen and ibuprofen doses. This combination is highly effective for both adults and children. I wanted to include the recommendation for pediatric-based dosing. Acetaminophen should be dosed 10 to 15 milligrams per kilogram every 6 hours with a maximum single dose of 1,000 milligrams. The dosing should not exceed 4 grams per day or a weight-based maximum of 75 milligrams per kilogram per day. Ibuprofen should be dosed 10 milligrams per kilogram every 6 hours, not to exceed 2.4 grams per day or a weight-based maximum of 40 milligrams per kilogram per day. These medications should be alternated, meaning every 3 hours the patient will receive acetaminophen or ibuprofen, day and night, until their pain starts to improve. There are rectal suppository options for patients who refuse to take their medication by mouth. However, suppository should not be used first line, but rather if the oral route fails. It seems like the postoperative use of ibuprofen is somewhat variable across practices, but it is becoming more consistent in recent years. Literature, including a Cochrane review including 13 randomized controlled trials with 955 patients, did not find a statistically significant increase in bleeding following tonsillectomy. Importantly, ibuprofen, when combined with acetaminophen, provides more effective postoperative pain control with greater safety than an opioid-based regimen. Aspirin, on the other hand, has repeatedly been found to increase the risk of postoperative hemorrhage. Krishan and colleagues performed a meta-analysis which included 1,368 patients and found the odds of a post-tonsillectomy bleed was almost 2 times greater when compared to the non-aspirin NSAID group. Diclofenac is an NSAID which has been studied more in the adult population. McKean, Lee, and Hussein found no difference between diclofenac and opioids in their retrospective review of about 200 patients, 100 of those in the diclofenac group. Bethula, Stern, and Valenti, at my residency alma mater, the Detroit Medical Center, found that diclofenac was reliable and safe for adult use when compared to patients using acetaminophen plus opioid or acetaminophen plus ibuprofen. Henney and colleagues analyzed clot strength in the immediate postoperative period after diclofenac was administered intraoperatively. They did not find that this dose of diclofenac adversely affected clot strength. Collins and colleagues reviewed different doses of ibuprofen and diclofenac on postoperative pain. They found similar efficacy between both medications. On to opioids. Should opioids be prescribed up front? I think this is a question many of us have. Will our patients suffer in pain without opioids? Will they be dissatisfied if they're not given a prescription up front for an opioid? Adler et al. Found there was no difference in parental satisfaction whether or not an opioid was prescribed. They did not note a significant difference in the proportion of patients with reported poor or inadequate pain control. So, should opioids be used instead of NSAIDs? We may think, surely opioids are stronger. In fact, NSAIDs seem to be better suited for post-tonsillectomy pain management. Souder and colleagues completed a multi-institutional case series of 672 subjects and found less pain reported in the ibuprofen group compared to the narcotic group. They also reported faster return to normal activity and diet in the ibuprofen group. Similarly, Kelly et al. Found no difference in analgesic effectiveness, postoperative tonsillar bleeds, or adverse drug reactions. These findings confirm NSAIDs are a more effective first-line analgesic than narcotics. Interestingly, in a study of 15,793 patients from across the United States, almost 2/3 of post-tonsillectomy patients received a prescription for an opioid. The median prescription duration was 8 days. This duration is actually significantly less than in previous decades. There is a trend toward prescribing less, as most patients do not finish their entire prescription. Opioids are generally not considered first line. They should be reserved for severe or refractory pain. Opioids should be used with caution, particularly for patients with obstructive sleep apnea. We have previously discussed the benefit of intraoperative steroid administration. The addition of post-operative steroids has proven to reduce post-tonsillectomy pain, although dosing and timing are not consistent in the literature. In a prospective study, Greenwell, Isaiah, and Pereira prescribed 1 dose of dexamethasone to be used on post-operative day 3. Their results demonstrate significantly improved pain control reported on post-op day 4, fewer post-operative phone calls, and fewer emergency department visits. Redmond and colleagues prescribed 3 doses of dexamethasone and found post-operative phone calls decreased by 9%, and the risk of a post-operative bleed dropped by 7%, from a rate of 9.7% to 5.7%. In a retrospective cohort study of 1,358 patients, where the study arm of 679 patients received prednisone daily for 3 days, Nolbit, Siddiqui, and Iverson did not find an association between steroid use and post-tonsillectomy hemorrhage rates. Topical anesthetics, such as lidocaine, in the form of oral rinses, mouthwashes, and sprays, are frequently mentioned for the management of post-tonsillectomy pain. Interestingly, most literature does not identify a benefit. A Cochrane review on this topic noted a trend toward the efficacy of lidocaine, but not other topical agents. The authors who completed the review mentioned that there is a paucity of well-designed studies to answer this question, and therefore a strong recommendation cannot be made. Honey has been used both as a food and medicine for thousands of years. The medicinal benefits of honey have been recorded in ancient writings. Honey, when used after tonsillectomy, reduces pain across all time points. Patients use less opioids and wake up less often during the night. Honey may or may not change healing time, meaning the time it takes for mucosalization of the tonsillar fossas to occur. The volume of honey and frequency of administration is variable across these studies. Even so, the benefit was detected. Acupuncture and acupressure have also been practiced for centuries. Acupuncture is thought to affect the nervous, endocrine, immune, cardiovascular, and digestive systems, putting our body back into balance, which can in turn help with pain and other conditions. The relationship between acupuncture and acupressure has been studied in tonsillectomy patients. Most of these studies performed acupuncture/acupressure intraoperatively by trained acupuncturists. They described the treatment as fast and well tolerated. The improvement from one perioperative acupuncture treatment is greatest in the short term, typically in the first 24 hours after treatment. This treatment may also help with postoperative nausea and vomiting. The figure of the oracle, captured from Shaw and colleagues, illustrates the acupuncture points used in their study. Keefe and colleagues, as well as Hanif and Frosch, studied the use of chewing gum after tonsillectomy, and found chewing gum in the early postoperative period significantly delayed resumption of normal diet and resulted in worse pain compared to the control group. Additionally, the duration of pain was greater in the chewing gum group, and they therefore recommend against the use of chewing gum in the postoperative period. The mind is a wonderful thing or a dangerous place, depending on the circumstances. Literature across specialties has been consistent. Concentrating on pain amplifies it. Distraction techniques, including music, games, interaction, reading, etc., helps reduce affective pain, which is defined as how the patient feels emotionally when experiencing pain. These strategies should be discussed during the preoperative teaching and included in the postoperative instructions. To briefly summarize, there's a black box warning contraindicating the use of codeine and tramadol in patients less than 18 years old. First-line pain control after tonsillectomy should include alternating doses of acetaminophen and ibuprofen. Aspirin should be avoided. Diclofenac is safe and reliable, although there does not appear to be a statistically significant benefit in pain control when compared to ibuprofen. Opioids can be used for severe and breakthrough pain, but should be used with caution, especially when prescribed to patients with obstructive sleep apnea. Steroids are helpful for postoperative pain with the added benefit of reducing postoperative phone calls. Steroids are not associated with increased risk of postoperative bleeding. Topical anesthetics have not been found to be consistently helpful. The addition of honey reduces pain, opioid use, and nighttime awakenings. Plus, it's really tasty. Acupuncture and acupressure is quick and well tolerated, which confers the most benefit in the first 24 hours after treatment. In conclusion, preoperative education is extremely important, particularly to manage expectations, discuss the postoperative pain management plan, and teach the patient and caregiver how to assess and describe pain. A single intraoperative IV dose of steroid helps with postoperative pain, nausea, and vomiting. Postoperatively, unless contraindicated, alternate between acetaminophen and ibuprofen. Use opioids for severe and refractory pain. Consider postoperative doses of steroids. Suggest honey as a supplement, and use distraction techniques. These are my references. Thank you for your attention.